This is the most terminal part of your finger. Now I'm going to talk on the mallet finger. These are very common injuries, as we see these in our country, especially while playing the cricket. Very commonly they keep on happening and patient doesn't, they don't keep on coming. So they say that I'm getting these injury quite often, but this time it is not getting healed. And they come with this deformity, that's dropped finger or the mallet finger. And these are common at the ulnar 3-digit, very common, less commonly at the index or more or less commonly at the thumb. So there are two mallets, soft mallet or bony mallet. Soft mallet, as the name it suggests, there is a rupture of the extensor tendon, and bony mallet, as its name suggests, there is a avulsion of the distal phalanx part of it. And if you don't treat them properly, this may land up into the swan neck deformity, as you can see in the picture. So assessing these injuries is very important because, as I said earlier, these are quite often, they come late presentation, and if they present, this is what X-ray we see. Typical PA view and the thumb and index finger pinching, and you may miss this injury on initial presentation. So what you need is a true lateral dead X-ray. So you can see whether there is a avulsion, and you can see whether joint is subluxating or not, so that can guide you for the further treatment. So they can be treated non-surgically with the splint, and the cases where these fragments are not getting reduced and subluxating volarly, they are the candidate for the surgical intervention. So you can put them splint that can give you dorsiflexion at the DIP joint. There is no need to put splint at the proximal. You can just put them with the one strap at the distal interphalangeal joint. And this can heal very well. So what are the indications for surgery? So there is a volar subluxation. As you can see, there is large bony piece and non-compliant patient and the failed previous treatment. So this was the patient we treated initially. Now this has developed the pressure sore at the dorsal side. So what are the options you have? You can put K-wires, mini screws, or the plates. Out of these plates, we don't have at our place, and these are very difficult to put, technically very demanding. So what we have is a K-wires and the mini screws. So here is a short video, which, as you can see in the X-ray, the volarly subluxating DIP joint, and there is a large bony fragment which is at the dorsal side. So patient is under digital block, and this is open reduction. So make your H-shaped incision, and be careful, don't damage the extensor tendon, just incise the skin and elevate the flap on dorsal side, and here you can see that fracture fragment. So once you cleared everything, you can put it back. Don't remove any bone there, just clear off. So it can, so with small amount of traction, you can put it back, and you can pass a 1 mm screw. So you can see it's nicely reduced. Now we can pass a 1 mm screw. You have to give the best here, because once you shatter the fragment, you have no other option to treat this then. So this is, you can see 1 mm screw. This is in AP view. Joint is congruous and nicely reduced. So what if you don't have access to these 1 mm screws? So here is another case treated with the K-wires. So you can see the splint is going all the way to the PIP joint, which is not required. And patient is again under digital block, and you can see there is a deformity. This was presented quite late. So I'm trying to manipulate, and joint is getting volarly subluxate, and the fragment is not getting reduced. So this was planned for the K-wires. So you can pass 1 mm K-wire in the distal phalanx. Then check under C-arm whether it is center. Now you stop here. Then you flex DIP joint and pass another K-wire just dorsal to that fragment. And now you extend and see that joint, the fragment is getting reduced and the joint is congruous. So to take home, don't miss them on initial presentation. This is quite common. We just do the AP and oblique view. Don't miss them. And majority of them can be treated non-surgically, and they can be fixed with the K-wires and mini screw. Mini screw should be the preferred option as you are sparing the joint. But if you don't have access and the procedure is technically demanding, you can go ahead and do the K-wire across the joint. Explaining that patient will have some amount of stiffness. Thank you.